From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, and welcome to our listeners around the world. I'm Dr. Kristin Walter, Deputy Editor at JAMA. I'm joined today by Dr. John Winkelman, Professor of Psychiatry at Harvard Medical School in Boston, Massachusetts. Today we will be discussing a JAMA article that he co-authored with Dr. Benjamin Whipper titled Restless Leg Syndrome, a Review. This article was published online in JAMA on January 21st. Dr. Winkelman, thank you so much for joining us on this podcast.
You're very welcome. Thank you for inviting me.
So to start off, can you describe the condition of restless leg syndrome and what are the common symptoms?
Restless leg syndrome is a movement disorder that has very clear diagnostic criteria. There is an urge, or some people might say even a need, to move, usually the legs, sometimes the arms, that's present at rest, gets better with movement, standing up, walking around, and importantly, is most prominent in the evening or nighttime. It has a strong circadian rhythm. So the mnemonic is a urge, present at rest, gets better with movement. In the evening, URGE.
And your article discusses the pathophysiology of restless leg syndrome and mentions several factors, including abnormal iron metabolism, genetic predisposition, and increased dopaminergic activity in the brain. Could you discuss these factors?
It's hard to know exactly which of these is the most important, but certainly there's strong evidence from GWAS that genetics is involved, probably accounts for about 20% of the variance of RLS presentation. People who have low iron, and here we're not necessarily talking about iron in the periphery, but iron in the brain. And those are two separate compartments. So people with iron deficiency will commonly have restless leg syndrome, maybe more likely if you also have the genetic predisposition. And somehow that then leads to dopaminergic and probably other biological neurotransmitter abnormalities in the CNS that accounts for the symptoms.
How common is restless leg syndrome among U.S. adults, and what percentage have moderately or severely distressing symptoms?
So if you go into the community and just ask people about the RLS symptoms, you're probably going to get about 1 in 10 people who say that they have these kinds of symptoms at any point, at some point in the previous year. Long plane rides, long car rides, anytime that they have prolonged immobility. But if we're talking about clinically important restless leg syndrome, which is present at least twice a week and associated with at least moderate distress when those symptoms are present, we're talking about 3% of adults. And this is true in the US and in Northern Europe as well.
Your article also mentions that approximately 10% of adults aged 65 years or older have restless leg syndrome, and it's more common among women than men, with a ratio of about 2 to 1. At what age do patients typically first develop symptoms of restless leg syndrome, and at what age do they typically present?
Well, when you talk to patients with RLS, let's say, I've had these on and off over many, many years. Women might say this showed up at my first pregnancy and then went away. But then 20 years later, it starts happening more frequently. And you get the same kind of thing from other people as well, who said it would only occur under certain circumstances. But it's now that I'm in my 50s or 60s, it really seems to be happening much more frequently. It's much more bothersome, and it's interfering substantially with my sleep. And women certainly have more RLS than men, possibly related to iron changes that occur during pregnancy. So nulliparous women seem to have about the same prevalence of RLS as men do, and more pregnancies do seem to be associated with greater prevalence of RLS. So iron is certainly important in restless leg syndrome. And remember, the brain and the periphery are separate compartments when it comes to iron. Iron is actively transported into the brain, and that's probably where the issues are with iron in RLS.
So just to follow up a little on that, how commonly do patients with restless leg syndrome have iron deficiency or iron deficiency anemia?
Uncommonly. Most people with RLS, when you draw their serum iron indices, they're going to be normal. However, as we may be seeing in a few minutes with your questions, we can give iron either orally or intravenously and get benefits from those approaches, even in people with quote unquote normal iron. For that reason, we say that treatment with iron should not be based on normal or abnormal values, but in RLS, we have a lower threshold.
And what are those thresholds?
Well, there's some controversy now, but certainly anybody with a ferritin below 100, and some people would say anybody with a ferritin below 300 should get IV iron. Similarly, anybody with a transferrin saturation below 20%, even though in some labs that is a very normal value, those people should also get IV iron. So this is kind of confusing, and confusing for insurance companies as well as providers, because the values are normal, but we're still supplementing with iron. It's because we can't trust these peripheral values as an indication of what's going on in the brain.
And you mentioned pregnancy earlier, and I wanted to follow up on that. Your article discusses how the rates increase over the course of pregnancy. Could you talk about the rates in first, second, and third trimesters of pregnancy?
Generally, I think about 5, 10, and 20% roughly first, second, third trimesters. Though I've talked to women who said, I could tell I was pregnant because my legs started to bother me again, even before I tested positive. So some people are obviously quite sensitive to that, and the developing fetus is hungry for iron, so is pulling it from the systemic circulation and depriving the brain of the mother from that iron.
And can you discuss how the diagnosis of restless leg syndrome is made?
It's made by clinical history. It's that most invasive of all medical procedures, questions. And it would be nice if we had a blood test, or if we maybe diagnosed it on sleep study, but it's just clinical history. At first, the screening question that I think anybody with insomnia should be asked, do your legs bother you at night? If they say no, don't worry about restless legs. If they say yes, then you go to the URGE questions. Do you have a feeling that you have to move your legs in the evening because you have some achy, creepy, crawly, tingly feeling in your legs? Is that feeling present when you are immobile, sitting or lying down? If you get up and walk around just a little bit, or even stand, do you get relief while you're standing or moving? And are these symptoms most common in the evening or at night? You get 4 yeses to the URGE, and then you probably have restless leg syndrome.
And your article discusses that sleep studies are not recommended to make the diagnosis of restless leg syndrome, but some patients may undergo this testing and may be found to have periodic limb movements of sleep. Can you describe these? And are patients with periodic limb movements of sleep more likely to have symptoms of restless leg syndrome?
Yes. Periodic limb movements of sleep are just what they sound like. They are dorsiflexion movements of the foot, flexion at the knee. They can be fairly subtle. They're quite common, particularly as people get older or people taking serotonergic reuptake inhibitors. I think of it like a Venn diagram. There's a big circle, which is a lot of people with periodic limb movements of sleep, and then a smaller circle, which is almost completely inside that other circle. The smaller circle being people with restless leg syndrome, almost all of whom have periodic limb movements of sleep. So when you see those on a sleep study, that certainly is not diagnostic for restless leg syndrome. Don't confuse the two. But I think it's warranted when you see a lot of those PLMS to then ask people, do your legs bother you at night? And then move forward with the rest of the diagnostic questions.
And in terms of treatment, your article discusses that initial management includes discontinuing exacerbating medications. Which medications are you referring to here?
The main ones are serotonergic reuptake inhibitors, but you want to certainly be cautious. You don't want to just say, stop that SSRI because they're taking it for a reason, but you want to talk to whomever the prescriber is and see whether it's possible. Antihistamines are certainly strongly influencing restless leg syndrome and can worsen it or can bring it on. Dopamine antagonists, whether those be ones that were used in psychiatry or used like metoclopramide for GI reasons, can bring on restless legs as well. And finally, alcohol. Almost everybody with restless leg syndrome says that even if they have one glass of wine, their legs really act up. And I hate to be the person to tell people not to have their glass of wine or beer, but they should just know that there's that connection, and then they can make the choice.
Are there other behavioral interventions or modifications that are recommended to manage symptoms of restless leg?
For mild to moderate restless legs, we find that stretching before bed can be helpful. Moderate exercise during the day is helpful. I say there's a Goldilocks level of exercise that's best for restless legs, not too much, not too little. Many people will find that massage can be helpful, or certainly a hot bath or a shower can be helpful, at least temporarily relieving the symptoms. So any of those things may be of value.
And then we discussed this a little bit earlier, about iron deficiency and who should be treated. I wanted to ask, when you have somebody who meets the threshold of the transferrin saturation of less than 20% or the low serum ferritin concentration, and you start to replete them, how often do they have symptom improvement with iron supplementation?
Well, both PO iron and IV iron have been shown in clinical trials to be about as effective as the medications that we're going to describe. If they meet the criteria, it's usually ferritin less than 100, transferrin saturation less than 20%. So in my experience, it's about 50-50. People will report benefit from the oral iron, but remember, oral iron is not absorbed if your ferritin is above 50 or 75. So there's a good range of people who are going to benefit from IV iron, but not be able to absorb oral iron. So in those people whose ferritin is, let's say, above 50, maybe 75, I'm not going to bother giving oral iron because it's not going to get absorbed. Hepcidin, this protein, prevents its absorption. So those people, I'm just going to go right to IV iron. But certainly not good for everybody, but it is worth a shot as a first-line treatment.
And when should medications be considered for patients with restless leg syndrome, and what is first-line treatment?
Medications should be considered when both the provider and the patient feel that they would like to have that symptom addressed. So shared medical decision-making makes sense. It's really a discussion between those two people. I'm not really one to say that it should or should not be treated. It's up to people for them to decide, because medications can have side effects that they then have to balance against the benefits. But for people who have significantly impaired sleep as a result of the restless leg syndrome, and therefore impaired daytime functioning or distress associated with their nighttime sleeplessness, I think it's very reasonable to consider medications. First-line treatments are the gabapentinoids. Their mechanism of action, they're alpha-2 delta calcium channel ligands. They don't really, even though they have gabapentin in the name, they may look like gabapentin, but they don't bind to the same receptors that gabapentin and pregabalin do. So they're first-line treatments, either gabapentin, pregabalin, or gabapentin N-acarbal. And all of those work in fundamentally the same way, but they have distinctions between the three of them.
And what is the efficacy of gabapentinoids?
Excellent. 2/3 of people are going to have benefit from them. Gabapentin itself, you need to slowly titrate up, I'd say pretty much the same thing with pregabalin. The disadvantage of gabapentin is if you do need to get to higher doses, it has nonlinear absorption. So if you go above 600 milligrams or so in a single dose of gabapentin, you're going to get erratic and oftentimes very poor absorption. So for that reason, I generally use pregabalin first because it has linear pharmacokinetics, and what you give is what the patient gets. And we try to get to about 300 milligrams of pregabalin if that's tolerated, generally once a day. If they have symptoms in the evening, you give it an hour or two before then.
There are also 3 dopamine agonists that are FDA approved for the treatment of restless leg syndrome, and these medications are efficacious, but chronic daily use is associated with augmentation. Can you define augmentation, and how commonly does this occur?
Absolutely. And this is a really important point because dopamine agonists are considered by most providers in the United States as first-line treatments. And I want to be very clear. At this point in time, they are not first-line treatments. Not because they don't work well acutely, because they do. That's the problem, is they work incredibly well acutely, and they make both patient and doctor very happy. However, over time, they make the restless legs worse. And this is a phenomenon called augmentation. And they make it worse in a very specific way. Symptoms start earlier and earlier and earlier during the day. And not only do they expand temporally, time-wise, but they expand anatomically from the lower extremities to the upper extremities. This happens at about an incidence of about 8% of people who take the medicines per year. And you think, well, 8% per year is not that much. However, somebody develops restless legs at 55, they're going to be taking this medicine for 20 years. Excellent chance that they're going to develop augmentation over that time. Doesn't necessarily mean they will develop augmentation, but there's a high likelihood. And that's not what we want to do. We don't want to make people worse over the long term. And certainly, if you're going to prescribe this class of medicines, you do want to warn them about this risk of augmentation, number one, and see them regularly, asking them about these aspects, earlier onset, expanded symptom distribution.
And for patients with restless leg syndrome who do not improve with first-line medications, can't tolerate them, or have augmented restless leg syndrome, consensus guidelines recommend low-dose opioids. What typical doses of opioids are used for these patients?
These are very low doses. The choice of this specific medication depends on the temporal distribution of symptoms. If you only have symptoms at bedtime, not before bed, or not in the middle of the night, you can use a short-acting opioid. And here we're talking about the usual ones, oxycodone, for instance, 5 or 10 milligrams. Most of the people, though, who are prescribed opioids for the restless leg syndrome are because they have developed augmentation. And they come to you now with symptoms 8, 12, 16 hours a day. They start at noon. They start at 3 o'clock in the afternoon. They have a standing desk at work. They have to get out of their car on their drive home because their legs are bothering them so much. And then they last the rest of the afternoon and all evening. And when people get in bed, they're terrible, and throughout most of the night. So they need 12 to 16 hours of coverage. For those people, we use long-acting opioids. And here we're talking about either methadone or buprenorphine. And the doses that are used for restless legs are about 10%, maybe even less, of what is used for chronic pain or opioid use disorder. So in my practice, my average dose of methadone is 8 milligrams. For buprenorphine, somewhere around anywhere from 0.25 milligrams, 0.5 milligrams, up to a couple of milligrams. For people with opioid use disorder, they get 16 milligrams. So these are very low doses, and they're extraordinarily effective. And at these doses, people just aren't getting any of the euphoria that people might be getting with the other agents at higher doses. However, constipation, common but usually manageable, maybe some daytime sedation with the long-acting agents. So you need to warn about those side effects, but generally people are extremely satisfied with these very low doses of opioids.
And can you discuss the use of perineal nerve stimulation for treatment of these patients?
Sure, this is a relatively new treatment. It's kind of like a fine-tuned TENS for RLS. It's a band that's put on bilaterally below the knee, and there's a stimulating electrode over the head of the perineal nerve there at the head of the fibula, and it has been shown in a number of blinded or sham studies to produce excellent treatment of RLS. The battery only lasts about 30 minutes, so usually people are using this kind of right before bed when they have symptoms, putting it on then, hopefully get symptom relief and are able to go to sleep, or in the middle of the night, same thing. Wake up with mild symptoms, turn it on, and get stimulation over the perineal nerve, and again, may get some benefit. This is FDA cleared for people who are currently taking other RLS medications, but have not been fully responsive.
Before closing, is there anything that we didn't discuss in this podcast that you'd like to mention?
There are some excellent websites for you to direct your patients to. The RLS Foundation has a wonderful website that has an enormous amount of traffic, and as a member of their Scientific and Medical Advisory Board for 20 years, has very good information there. There's a really nice website for providers who have RLS patients that they're having difficulty managing, and this is called RLS Curbside. So if you just type in RLS Curbside, you can get a curbside. There's a template. You just put in some relevant clinical factors about the patient. There are about 275 people who are registered for this, who will then weigh in on how they might help you manage this. The website is non-commercial. It's free. You do need to register as a provider. This is not for patients to be able to do these curbsides, but because we don't see each other as much as we used to in the hospital, this is a good way of us communicating with each other.
Thank you so much for sharing your thoughts about this interesting and important topic. I'm Dr. Kristin Walter, and I've been speaking with Dr. John Winkelman, professor of psychiatry at Harvard Medical School in Boston. You can find a link to the JAMA Review article we discussed in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.